Okay. My name is Mark Bolin. I'm with Oklahoma State University, and today I'm talking with Micah Bolin about their experience during the COVID-19 pandemic in Oklahoma. We will be focusing most of our time discussing their role as student clerkship and fellowship coordinator at the University of Oklahoma. But I have some more general questions about life during this time. Upon this agreement of Micah, this interview will be archived at the Oklahoma State University Library for future generations to see. Just so you know, this is being recorded for a class, but it might be used for future generations of scholars. So it will be housed at the library. Okay, Micah Bolin. Can you give us your job title now? And I know that's different from the job title you had previously. So give us your job title now and the job you held during the COVID-19 pandemic.
Yeah, so my current job title is I'm education coordinator at the University of Arkansas, School for Medical Sciences in Little Rock, Arkansas. Just a short, brief introduction about what I do is I oversee the medical school aspects for all educational learning for medical students, PA students, nursing students, things like that, instead of just department-wide, which at the University of Oklahoma, I was with the surgery department specifically and oversaw the educational aspects for the third and fourth year clerkships, which is their medical school clinical education. I also oversaw the residential side of surgery, which was the fellowship, which is the PGY 6 and 7s, which stands for postgraduate year. So I oversaw the specific specialties that people would go into after they finish their residency in general surgery, specifically in vascular surgery. So those were these are my two positions that I've held at the University of Oklahoma than my current position with the University of Arkansas right now.
Okay, so what's your education in? What are your degrees in?
So I have a Bachelor of Arts from the University of Tulsa, specifically in pre-law. After that, I have a Master of Healthcare Administration from Oklahoma State University, focusing in healthcare policy, medical school education, and medical school or medical law.
Okay, so let's talk about your job specifically, because you have some unique experiences with COVID-19 and the pandemic as a whole. What can you tell us, can you walk us through like what your job consisted of before the pandemic? Like what were your day-to-day activities like, and what, if you can remember before 2020, what was your job like before then?
Yeah, so my job was unique in a lot of ways. So I saw, like I said, medical school education is one aspect of was part of my job, but then also the residency and fellowship is a totally different side. So I got to see kind of two unique perspectives of education from the medical side of things. I got to see medical students at the very beginning of their education all the way through, like I said, the PGY 6 and 7s who are finishing up and going into their actual career after, 12, 13 years of medical schooling, residency, and then fellowship now. So I'll kind of divide it up into my two sections. So from the medical school side of things, I would oversee my main aspect was the third year medical school or medical students. Third year of medical school specifically deals in their clinical aspects. So they're actually within each department every day, essentially doing the job of the general surgeon, waking up at 5 a.m., being there at 5:30, going in, rounding in the hospital, overseeing patient care, and then doing that all day, all the way until about 6 or 7 o'clock at night. So my aspect of that job was to oversee the educational requirements from the medical school. Specifically, there were requirements that they needed to complete during their 8-week clerkship, which is what we called their rotation with us, was a clerkship, and ensuring that all of those aspects were met so that they could move on to their fourth year of medical school as well. So I would oversee the day-to-day operations from the time that they got there, making sure they're procedures and diagnoses were properly completed, lectures were done, and then all the grading aspects that went into medical school education, I oversaw that as well. Now switch to the fellowship side. It's a whole lot more different. It was overseeing people who were essentially working underneath me or with me, making sure that they were completing their certain, as well as what happened in the medical school, their requirements that they needed to graduate to become full-fledged practicing doctors after residency and fellowship. So completing work hours, completing case logs, which is what they would do after they would see patients. They would do cases, anything along those lines, ensuring that they were properly licensed and ready to be full-fledged specialty doctors at the very end of that. That's what I don't want to say day-to-day, because so many things happen in surgery that you really can't predict what a day-to-day aspect would be. But those were the general ideas of what went into my job every day.
Okay. So let's see here. I have several ways I could go with this, but let's talk about the early outbreak and the pandemic declaration. What are your memories of first realizing this pandemic was going to significantly affect your day-to-day life?
Yeah, we were, obviously working with doctors and being on that side, and especially being in a hospital. We saw this and we were taking early precautions, even though things weren't necessarily being done from an outside point of view. We, as a department and as a university, were making the preparations because we knew this was coming and we knew that it was going to hit. When it finally did hit, I remember specifically it was a Thursday. Things just seemed to be going normal, and then all of a sudden we get the declaration from the university saying that everyone is to close everything down and go home by 3 p.m. that day. Medical students are to go home, complete any clinical aspects, and then go home. From there, it was just kind of a state of confusion. We didn't know what the next steps were, or if we would be back, the following day, following week, following month, what was going to happen with that. And then the same with the residents and fellows. Unfortunately, they were kind of left in limbo at the same time because they're practicing doctors. They were left in the hospital. A lot of cases were still going on, and there was not a lot we could do from a university standpoint because they have patients that were taken care of. They're on a 24-hour basis, essentially. Surgeries, post-op follow-ups, clinic follow-ups, things like that. So it was really interesting to see from a medical school side, seeing everything shut down literally in an afternoon, to the residency and fellowship side, seeing things just continue on as normal business. But then the interesting thing about that was also monitoring what the medical students were going to be doing for, the following weeks. We assumed like I said, we didn't know how long anyone would be out. But the following days after that were just weird. That's the only way to put it. It was a very bizarre time. We sent the medical students home that day. We told them we really don't know what's going on. We don't know what to do. Enjoy the long weekend, essentially. Then with the fellows, it was take as much precaution as you can. You have the PPE you need. We've stocked up on this for a reason, but you just continue on with business as usual.
Wow. Wow. So you mentioned that from the administrative side, you all saw this coming. So this afternoon that you're talking about, when everything shut down, that was in March, right?
Yeah,
that was. And go ahead. Tell me about like that process.
Yeah, first week of March. There was not really a process. We got an email mid-morning saying that we're going to be shutting down. Medical students need to be sent home. Any non-essential staff members need to be going home too, and prepare to be working from home for the time being. But obviously, time being, we didn't know if that was, again, days, weeks, months, what was going to happen. So from the preparation side of things, we we had stockpiled boxes to literally pack our offices and go home and work from there. Um, so going forward with that, it was just that day it was a little chaotic just because there were so many questions we didn't have answers for, and we also had the same questions for everyone. But you mentioned seeing this in preparation for it. There was really no denying that it was going to hit. It was just a matter of when it was going to hit. Like I said, working with doctors, you get the latest updates from the state, from the federal side as well, sent to you every day, and you review those. And a lot of the faculty meetings that our professors and doctors would hold together, they would discuss the rising numbers, the trends and everything, and what the preparation plans were going to be for everyone. So it wasn't any real surprise for any of the doctors within our department or within any of the other departments at the University of Oklahoma in Tulsa, that this was coming and it would happen.
Wow, that's interesting. So for most Oklahomans, I remember the first. I remember everything shutting down really around the Oklahoma City Thunder game when they played the Utah Jazz and Rudy Gobert ended up testing positive for COVID-19. And it seemed like everything shut down after that. So you're saying that hospital administration at OU knew before that incident, and they actually shut down before that incident. And so, and you mentioned you'd have been stockpiling PPE, personal protective equipment. And I remember there was a shortage of personal protective equipment. So approximate, for me, this is interesting because lots of viruses come out every year and lots of mutations of viruses and everything else. And so obviously the University of Oklahoma, Oklahoma Medical, hospitals in general can't stockpile PPE based on every virus that's out there in the world. So what made y'all think this was going to be a big deal? Like what was different about this virus and this pandemic as opposed to, say, like the Zika virus and all those kinds of things?
Yeah. Speaking from a medical professional side, I don't have a doctorate. I can't really say what went into, we had great leadership and position to make these decisions, but I think just the unknown that went with everything and the quick spread. When one area was affected, it was essentially the entire area was infected as well. And just, I think seeing the spread is what really raised concern for everyone, because everyone saw on the news how quickly it spread through China, and as soon as it entered the United States, it spread through the northwest, where up in Portland and Seattle areas. I actually have a friend who was a traveling nurse who was in a COVID unit at that time. She was literally a weekend when COVID hit. So I think everyone saw the spread of it as, we don't know what this actually is, just an unknown variant of it. To stock, I will say, people was at that point. So I know a lot of our doctors were making special phone calls to anyway find any kind of stockpile we could get PPE, because even if it was short, or even hospital staff and everyone as well. So I think did was admirable. They were willing to take care of not only the medical students themselves, also the residents who were there who never went during COVID. I remember our residents and our fellows worked on a skeleton staff all the way through COVID. There would be, out of the, I think 25 or 30 residents and fellows that we have just in our department, I think there'd be about 5 to 6 residents there for 24 hours at least, and switching back and forth on different shifts. So when everything else shut down, our residents and our fellows and our doctors were all still there. So I think they made the preparations that they saw this was going to happen, and they jumped on it essentially.
So you've mentioned PPE several times. Did you wear PPE? If so, do you remember the first time you put it on? Did you have problems getting access to those things?
Yeah, I still wear PPE to this day. Our hospital here at Little Rock does require it. When I was at the University of Oklahoma, it still required it, and all hospitals still do. Um, I don't remember specifically the first time I put a mask on or anything, or use the hand sanitizer or gloves or anything, but I remember when we did have to go up to the office. You don't pack everything like you're packing for, you working at home for months and months at it ends. So whenever we did have to make the runs to the office, we would have to file a form with the University of Oklahoma and make our business manager aware we're going, we're planning to be there, mask and glove up. And that's what we did for the first month and a half while we were at home. Is if we had to go to the office, those were the steps that we had to take. Really the first time that I specifically wearing PPE every single time I went out anywhere. When COVID first hit in Oklahoma, I remember it was on that the Tulsa Health Department uh, announcement, and that's when we kind of realized this is here now. And that's when people started wearing masks, and I remember sporadically wearing masks at that point because, again, I didn't know what this was, and I'd rather be safe than sorry than with anything like that.
Right. So what you see me doing here is like our internet is like really, really bad. So I'm seeing if I can unplug my Ethernet and plug it into my computer real quick to hopefully stabilize our connection because we've been cutting out a little bit. So don't let this distract you too much because this is actually really, really interesting because this so okay, let's get back to this because how did the lockdowns affect not just your day-to-day work life, but how did it affect your day-to-day activities in general? How did it affect, work and your family life?
Yeah, work life, working for a medical school, it affected everything. We essentially had to put a brakes because since, like I said, the third year of medical school, you're in the hospital, you're in the clinics, you're in the surgeries, you're in the patient's room, you're in everywhere that a doctor's in. So when they told the students you're going home, we had to create a new curriculum for how to teach them because we still had to get them through their clerkship. They still had to get a grade, and they still had to move on. It's not like we could just, okay, well, it's not like you can just stop and say, well, COVID happened, you'll get a passing grade because of this. We had to move so many things online. We had to find different learning modules for them that would interact the same way as if they were in the hospital. So that was creating an entirely new educational agenda for a medical school that's no one's ever seen before. That was the main challenge with work, from the student standpoint. From the resident fellow standpoint, it was constant check-ins. It was how many exposures did you possibly have today? Do you need to fill this form out? Do we need to have this done for you? When do you need to go home? When, like, work hours were a critical part of, not only critical work hours are a critical part of any residency and fellowship. I'll say that. That's something that is monitored by not just the university, not by the department, but by the governing body, which is called the ACGME. There's a minimum of 80 work hours per week that a fellow is supposed to have, and a fellow and resident are supposed to have. So when COVID hit, you were essentially reaching these peaks. So it was constant check-ins to make sure that the fellows, the residents, were not overworked. They had the time off that they needed to, and we did that for them because it was constant monitoring. We didn't want our fellows to feel overwhelmed because COVID was a stressful time at this point. There were so many unknowns that no one had dealt with, new medical aspects that no one had seen before. Our fellows in vascular surgery are dealing with what they call COVID feet, which is essentially blood clots in the feet from post-COVID patients due to poor circulation. And this is something new that is happening now, that our fellows, our residents, all sorts, and other doctors are experiencing the same different COVID variants. I don't want to say variants, uh, post symptoms that no one's seen before. So it's a lot of stress on these people who are trying to finish up their education, go into the specialty or whatever they want to do. So making sure that they weren't overworked, making sure that they had the support they needed, making sure that they had the resources if they were exposed, things like that. So it was a lot of wear and tear, and especially working at home, it made it, pretty difficult. I would see my students every morning. I would see them throughout the day. They would stop in my office. I would talk to them, see how their day was going. So not seeing them was an interesting aspect. I remember there was one specific rotation that we had of medical students that our entire interaction was all over Zoom. So I've never seen those people in person. But then also with our fellows, I would see them a few times during the week. And our interaction turned to Zoom and text messages saying, hey, what do you need? This is what can we do for you? Send me your work hours. Let me check on these things for you. So a lot of bridges we'd never crossed, and a lot of things within the educational department and education community no one had ever seen before. Obviously with COVID, it starts square one. No one had seen COVID before, but then the trickle down effect was that there was a lot of things no one had seen before, and trying to deal with those aspects was the stressful part for the first few months. The medical education was there, but I don't think it would be the same if COVID would have happened. So those were just some of the things that were affected from my work standpoint. From home life, it was, I'm staying in my room. I had a roommate at the time I was living with, and we didn't interact because we just didn't know from day to day what was going on. So a lot of self-isolation, a lot more deliveries than I've ever done in my life. A lot of yeah, it was interesting. It was an interesting time. I didn't see friends for months, didn't see family for weeks, months at a time. So it was an interesting aspect, navigating that as well as home. You have the work stresses, but then you also have the at-home stresses that go into it as well. So, but we made it through. That's the best thing that everyone says in the medical community is, we made it through COVID at that point. Still dealing with it, obviously, but we made it through that first surge, and I think there are multiple things in place in case there is a surge again for medical education and medical communities as well.
So you've talked about, okay, so getting back into your personal life, what activities because the medical field is a stressful field in general, whether you're in the administrative side or whether you're in the doctor, patient, nurse side, whatever. So what were your leisure activities, your stress relieving activities before? Did those change during COVID? If so, how?
Yeah, they did. I love to play golf. I love to hang out with my friends. Going out playing golf is the main aspect that was a de-stressor for me. I would go out on Saturday mornings with a group of friends and go play golf. Then that changed when things shut down. Golf courses were obviously one of those things that shut down. But then I would also, during COVID, I would go on runs alone. It was finding whatever you could to do to get yourself out of the house, because at that point your house was also your office. And I found myself getting antsy at times and needing to kind of separate my home life away from my office life. So that included moving offices, essentially, moving rooms multiple times a day. When I would finish up with work, I would go on drives just by myself, listening to music as outlets, doing whatever I could just to get away from the office side of the home. And then, kind of separating that was a big key for me. So I think, I still had the social aspect because I'm a typical millennial and I have my cell phone with me, so I could FaceTime, I could call, I could text any of my friends. Then we'd also adapt to the changes. We would have Zoom movie parties or Zoom parties, we would call them, where we'd all just get on Zoom and talk to each other for a few hours and just essentially to say how's home life, how's work life, what's going on with this. So I think, it was an adaptation that we had to make, and it was just weird, going from completely open to everything shut down. I remember I was supposed to be on a one of my best friend's bachelor parties, to Miami, but that was the week that OU said there was no traveling. You can't travel anymore. I had a group of friends who went on the bachelor party and thought I was making things up, that COVID wasn't this serious thing, that my university was overreacting. I was trying to get out of the vacation or whatever. But then when they were coming back from Miami, that was the day that Miami Beach closed and airports started shutting down. And they were like, well, you might be right about this. This might be a real thing. So yeah, just closing down of social life was an interesting aspect, trying to handle it. But there were, thank God for technology, because that helped save a lot of things, especially social life, and then also work related as well.
For sure. So you've mentioned, and that we're going to have to talk about this because this is all a part of COVID. So you mentioned that your medical community instituted a public mask mandate, and they had strict regulations, as far as I remember, about hospital visitations and all that kind of stuff. How did you feel about that personally, and what was the general response in your community?
I thought it was the right idea. I thought the shutdown was essential. There were too many. Where I worked was actually within one of the community-based. So the University of Oklahoma in Tulsa is a community-based education program. So what that means is they're within each of the hospitals that are in Tulsa, Oklahoma. So you have three main hospitals. You have Hillcrest, St. John, and St. Francis, and all those essentially shut down for everyone. The only way that we were allowed in was badge access. So you had to be on whatever hospital's roster to get into the buildings you were at, or else you had to go through just the general screenings at the front of the hospital. Even at where I'm at now in Little Rock, we still have screenings. You still have to be scanned at every entrance that you go into. Do I agree with it? Absolutely. I think you should screen as many people as possible, because you're in a place where people have immunocompromised situations. People are there not because they're doing well. It's people are there because they're sick, because they need something. And when you're put in those situations, I think they take every aspect of the mask mandate, of the screenings, of everything, of the cleaning, the sanitation, and whatever you want to say, very seriously, because it's needed. For my community, we were all on board with it. We practiced the 6 foot rule. We all had stop signs at our door that said, "This is as far as you can come, as close as you can come to my desk." We also operated on a closed door policy. You would have to knock to be able to gain access to our rooms if we wanted to even let you in. It's still in effect for some people. I know when I left the University of Oklahoma, some people still had that operation going on with them. So I think as a whole, as a community, the medical community within the University of Oklahoma was very accepting of that, of the mask mandate, especially.
So, what did you see any resistance to it? Did you experience any resistance to it? Or what was the resistance to mask mandates and all the protocols set forth by the Centers for Disease Control and the federal government?
I don't think I saw too much from, my standpoint. My standpoint was I was kind of behind the scenes of a lot of the medical aspects of things. Would there be times when people would forget a mask? Absolutely. And that was just, it's so new to be told you have to wear a mask everywhere you go inside somewhere. So naturally it happened. And also with the 6 foot social distancing rule that we had in place as well. It was something no one had ever experienced. So tendencies like that did happen, where where people would just forget. But as of resistance, none of our doctors, none of our students, when we did finally come back to be in session, none of them have had any resistance. They've all been accepting of it. They all understand the risks that are involved with COVID-19, the direct spread and what goes on with that. So I never saw any resistance from our faculty, our students, our residents, our fellows, any of the academic, medical, or education staff. That included me and the other coordinators. But it was just like I said, it was a tendency sometimes just to forget. Sometimes, like I said, it was so new for so many people to have these parameters put on them that they just tend to forget sometimes.
So how did you feel about the information you were seeing related to the pandemic, and where did you get most of your information?
So that's really interesting that you asked that. We got our information. It's going to be very difficult to explain because working in a healthcare facility, you would get 4 or 5 different emails that would go over to the different variant. They're not the different variants, the spikes, what was going on in certain cases, certain counties, things like that. And especially working for a state organization, you would get a number of emails saying what this was going on. So the University of Oklahoma in Oklahoma City would send out the first email I would remember seeing in the morning when I come into work, updating on the daily numbers, what they had seen in their specific facility in Oklahoma City. Then when we get one where I worked at St. John Hospital in Tulsa, and I know all the other hospitals provided what they did as well, from their specific hospital bases, how many patients they had, how many COVID people had come in, what the overall infection rate was going on throughout the hospital, things like that, what floors were off limits. So I think those were 2 of the main things that we looked at as well. Luckily, we did have one of our doctors was a really good statistician and created his own variants and his own tables, and would send those out to our entire faculty. And he would discuss those during faculty meetings and specifically in certain meetings that we would have with him. So I think getting as many, and then we also take the CDC emails as well, and he would combine those into his statisticians as well, his statistics as well, excuse me. So those were the 4 main sources that we really used, and we'd get those, almost daily. I think from our doctor, he would send those out, once a week, but the rest of them were daily updates we get from the CDC, our local hospitals, and then also from the University of Oklahoma as well. And that's what we really relied on, because we knew what our hospital was doing, we knew what our university was doing, and we knew what the CDC was doing essentially too, and what they were looking at overall.
So you weren't watching like CBS or ABC or Fox News or NBC or any of those to get your information, right?
Not essentially. I mean, in passing on TV, you would see those numbers, and you can't help but compare those to the numbers that you've seen that day, from your hospital, from your university, from your specific faculty members at the University of Oklahoma as well. So you would see those and kind of compare them, and you would just look at them and compare it. Essentially, is what I would do. I wouldn't say that was a reliable source that I would go on, because I had so many people sending me their specific sources. So from the University of Oklahoma, our faculty, our hospitals that we were at, and then also the CDC. But you can't say that you didn't look at the numbers that came from, those national media websites and television stations, and say that you didn't see that. But taking it for a grain of salt, and what you see from the people that and then also what has been broadcast, you just kind of sit there and compare those essentially.
So how did you feel about that information that you would see like on public sources, like say on the evening news, or versus what you were seeing in-house in the hospital?
Yeah, it's hard to have you try not to have too much of a bias because you're there firsthand experience, so you're hearing from the doctors what's going on. But I thought a lot of the national media websites and media outlets, they provided decent statistics. There would be some that would be completely off. There'd be some that were, marginally off, and then some that would be just right on. So I think dependent on who you would watch, it was just you had to make a judgment call essentially. But again, I being totally biased, seeing it firsthand, we were speaking from our point of view, we were essentially out of the office for about 2 months before we started doing a skeleton schedule for the academic staff. So you'd get updates, like I said, from hospital staff, from hospitalists, other doctors as well. So just experiencing that firsthand, you would already create a bias because you know what it's like in the place that you worked at. But like I said, for majority of the media outlets, provided a pretty decent picture for what was going on. I think everyone knew how serious it was, but I think majority of them provided at least a decent, accurate statement of what was going on.
So we know that this pandemic became a political issue on several levels, for and against. And how did you feel about that personally? How did the people you work around, how did they feel about this virus becoming a political issue? And did you experience anything within the hospital setting or within your work setting that was affected by political biases?
Yeah, I think a lot of us just got tired of it. Honestly, I think we saw what was going on, even though I wasn't in the specific hospital rooms or the surgery rooms, patient rooms, things like that. We had direct access to the doctors that were taking care of these COVID patients. And then we're not even just COVID patients, all patients in general. And the interactions they would have to have before they would be able to see the doctor. That's from the patient side. And then what the doctors would have to do to see these patients. So when this really started turning into a political debate, and taking over the political atmosphere, me and a lot of my colleagues were tired of it. We didn't see how this pandemic could be turned into a political agenda or anything like that for one side or the other. We saw it as a global health crisis, as pretty much all doctors and all healthcare workers did see it because they interacted with it on a daily basis. Even though we weren't in the rooms, we indirectly dealt with it. We saw the strain it put on our doctors, our students, the other medical staff that we had, from our nurse practitioners, our PAs, our medical assistants, our nurses, our front desk workers, even in the clinic. We saw the stress it was putting on them, and then the stress it was putting on us as well. So when it got turned into a political debate, and is this a real thing? Is this whatever you want to say? I won't even go into that. It just got exhausting very quickly for myself, and that's not saying much because I worked on the backside of everything. I worked monitoring medical students and fellows and residents. I can't even imagine what it was like for those people who were actually going into the patient rooms and seeing patients directly face to face. So like I said, we got tired of it. It was something we didn't want to deal with. We didn't understand it, why it was being turned into this, why I was doing this and that. Then did I experience any biases with it directly from, the medical field? I don't think so. It was, I think, more of our doctors and students and everyone else faced that directly. We were all on board that this was, like I said, a global health crisis that we needed to help these people through, and these people, we mean our doctors, our healthcare providers. We need to help them through because they're helping, the general population get through this as well. And, it's interesting looking at that now because we were training the future doctors to take care of COVID, essentially. Um, so we were trying to provide as much support to them as possible. So when it got turned into a political debate, that was something we just got tired of very quickly, and we generally didn't understand it because it was never supposed to be like this. It's a global healthcare crisis that, everyone should be doing the best for each other instead of, what's better for you or the other person, instead of everyone's looking at it as possibly a sole possession or a sole purpose, instead of we're taking care of someone else.
So with that, did you experience any, because it did turn into a political debate, did you experience, did you get any interference from any political offices or figures that affected or tried to affect your day-to-day activities within your work setting?
At the end, it was the debate of mask mandates. And I think a lot of what went into that was everyone was tired of masks. But the science is behind it, from everything that I've seen, from what I've read, from what I've been told. And, I trusted the doctors who I was around because they were providing very good healthcare to the population in Tulsa. But from just a direct point of view, no, we didn't see much of that. But that was something I noticed kind of at the end of my tenure at the University of Oklahoma, was going into this, because we began filing, obviously the COVID vaccines were beginning to be a requirement at many of the hospitals in Tulsa for employees. But none of our residents, fellows, medical students, faculty, academic staff were opposed to that. People were lining up to get shots, getting boosters, doing whatever they could to get that as quickly as possible. Just from what I've heard from the outside and what I've seen is there's been, obviously some resistance to that. But a lot of all the people that I worked with didn't quite understand what the resistance was for that. Everyone was, like I said, on board with what they needed to do for the vaccine, for mask mandates, things like that.
There was a movement here at Oklahoma State, and there were several movements, a student-led, faculty-led, or otherwise staff-led, and a lot of them had to do with information, and the information that was coming out, and the information that a lot of people perceived as being out there. And of course we know, Governor Stitt, he at one point he was wanting to control the information coming out of hospitals or from the director of the state health department or something like that.
Yeah.
Do you remember that? And do you remember that affecting where you were working, or did you have personal experiences with that kind of political interference in the dissemination of information?
Yeah, I'll say it. Yeah, we did. And this kind of goes back to kind of the biases that I created because I was seeing what was coming out from, our hospitals, our university, and, the CDC as well. A lot of that did not match up. It was kind of frustrating at times, just from a personal standpoint, seeing what was coming out from Governor Stitt as well. But it was, I did my best with my personal life, my personal friends, my family, to try to inform them about the numbers that I saw. I mean, I'm no statistician. I'm not a math person. You can tell me 2 + 2 = 5, and I probably agree with you. But that the numbers that were coming out just didn't make any sense. I just remember having conversations with family, friends, and everyone in between about what could be possibly, what would these numbers, like where were they coming from? Because I was seeing, again, 3 to 4 different sources saying that this is actually what's happening, and hearing conversations about, well, this is what's happening in the hospital. This is what we're seeing from our point of view, from our residents, fellows, medical students, medical staff as well. But did those numbers affect any of us? No. From our residents and our fellows and our other faculty members, they knew what they were taking care of. They knew what was in front of them. They knew the risks. They knew everything that was going on. They knew the screenings that were involved with each patient that came through. So I don't want to say that it affected work life at all, because the doctors knew what they were doing. They knew what they were handling. They knew the numbers. They knew what was available, what wasn't available. They knew all sorts of things like that. So they just kept going on, and admiration for them, because they never stopped, despite what may have been put out, may have not been put out.
So would you say, like, because you talked about a discrepancy in numbers, would you say like the numbers were inflated, deflated, or both? Or how specifically, how were those numbers different from what you were seeing on the ground? Like what was the media perception versus what you were seeing physically at your job in the medical community?
Yeah, from my personal standpoint, what I saw, numbers were definitely lower as reported. From what I was seeing, it seemed like it was not that big of a deal from what was being reported. Whereas with the numbers that I was seeing from the multiple sources that I had, we were in crisis mode for a lot longer than what was being said and being presented to people. When I think there was a time in probably last summer, so summer of 2020, I think October or August or September of last year, when we kind of really started to hit our peak, is what was being said. A lot of people in the medical community said that there was no peak. There was, it had not, or sorry, plateaued. It had plateaued the numbers, but we were still rising. And that was that. Those were kind of the frustrating things. You would hear, local reports saying that we were plateauing, the numbers were, leveling off, we're making it through this. But then from the reports that we were seeing, the number of patients that our hospital people were seeing, it wasn't that at all. And I think one of the statistics that really started affecting a lot of people was hospital beds. I specifically remember a lot of times seeing hospital beds being available, this and that, but then hearing conversations that these aren't true. We don't have those at this place. We don't have them at that place. We're flying people here. We're flying people there just to get hospital beds. So I think that was a number that was grossly underestimated in reports that were coming out. So seeing that and having those, I don't think those affected what our doctors saw, because our doctors knew exactly what they were dealing with when patients would come in.
So just for clarity's sake, you're saying that there were hospital beds available when they were saying they weren't, or the opposite? Okay.
Hospital beds were not available. There were times when there would be grossly, maybe one for weeks on end, maybe even none, when it was reported that there were plenty of hospital beds available across the state. And it was not just across the state, across the region. It reached Oklahoma, Missouri, Arkansas, Texas, Kansas, and New Mexico. I remember, hearing one time that there was specifically someone trying to be transferred somewhere, and there was no place for it. And I think that's just kind of a national narrative of it, that was something that was going on regularly at hospitals across the nation, finding places for people to stay.
So there's a couple things I want to get into before we wrap up, but because this is interesting. So with that, with the idea that's I guess I want to ask, what were your personal, did you have any personal um, interactions with COVID-19? Did you experience COVID-19 on a personal basis? Did you know people that passed away? Did you know people that got the virus? How did that affect you and your work? Were you more careful, less careful? You know, how did that all go about?
Yeah, so I'll just say it. I experienced COVID-19 myself. I caught COVID in September of 2019. No, sorry, 2020. And I was symptomatic for a few days. I was running a fever, fatigue, all those symptoms, but luckily my symptoms only lasted for about a day and a half, maybe 2 days. Um, Honestly, I have no clue where I contracted it. At that point, COVID was so rampant. Um, Everyone was taking every precaution. So I wasn't seeing friends. I wasn't seeing family. Um, so my only thought is just in passing, no clue where it came from. I had friends who had family members die from COVID-19. Um, I had other friends who also contracted COVID-19 and experienced more worse symptoms than I did. So yeah, on a personal level, I did experience it. It was difficult to see my friends and their families struggle with the deaths that happened, as well as seeing entire families catch it. I had one of my friends who has multiple children. They were all down for about 2 weeks consecutively, out of work for time. But luckily they were still on the job. But it affected you longer than just the 2 weeks. I remember personally experiencing the fatigue for nearly a month or so, at least. And it's something that I can't help but think of sometimes. If I'm getting tired, I'm like, is this something that is a side effect of what I experienced and what I caught? um, so those things always go through your mind. It's also, working in the medical field, you hear about all these post-COVID symptoms that people have, whether it be long-term, short-term, whatever it may be. Those are also on your mind at all times. How will this affect me at some point in my life? Because I did catch COVID. So it's a wary thing. You worry about it, you think about it, but you try not to dwell on it. So those are just my personal experience with it. I've seen people contract the disease. I've contracted it, or the virus. I'm sorry. So yeah, those are just things that I think about just in my personal life with that.
Hmm. So you talked a little bit about it. I heard the term COVID feet. What's because I'll be honest, there's some things that you're privy to in the medical community that people like me who aren't in the medical community, things we don't know about. So what are some of the other things we might not be aware about as far as long-term effects go, and also as far as like I guess just the long-reaching effects of COVID-19, both psychologically and medically?
Yeah. So psychologically, like I just kind of spoke on this, it's a wary thing. No one knows what this disease is long term, and it has multiple effects that people are saying this is caused from COVID, whether it be shortness of breath, be some types of lung disease, vascular insufficiency, which kind of leads to what you mentioned, the COVID feet. Um, COVID feet and COVID legs are becoming more and more apparent. It's poor circulation due to blockages in arteries and veins. I can't speak specifically on it because, again, I'm not a medical doctor. But just hearing about those, and also from, pulmonologists and other hospitalists, internal medicine doctors, just what has gone on with these different things that people have experienced with COVID. So that's something that, working in the medical field, I think that's why I think about it so much, is because I hear these things from these doctors, that I think about for my long-term health going forward. So, the best thing that they tell me is just to do as much as you can to live a healthy life. Whether it's getting out, eating healthy, doing whatever you can just to prevent anything like this, doing as much as you can for yourself, because we don't know what possibly could happen in the future with things like this. So psychologically, that's what wears on me a lot of the times of the day, is thinking about, just thinking about the unknowns, because there's no answer for what possibly could happen to me in my personal life, because I did have COVID. Whether there's some long-term effect that I just don't know about, that's just lying around, whether I'm just completely over it. So that's just kind of the things that go into your mind when you did have COVID, or when you do have COVID in the past. So I think there's a lot of psychological aspects that people think about, but then also just the physical long-term effects that some people are truly experiencing, are definitely on people's minds, not only the people who have it, but also the medical professionals who are taking care of it, because again, this is something new that they're even seeing.
Wow. So knowing what you know now, having experienced everything you've experienced, both professionally and personally, what do you think that individuals, communities, or policymakers need to keep in mind for the future?
That COVID's not going away. That's key number one. It's evident that COVID is here to stay, by the different variants that even we're experiencing today with the new variant that just came out within the past few weeks. Whether it be more severe, less severe, more contagious, less contagious, COVID is here to stay. I think that's something that everyone has to keep in mind. I think life forever has changed because we will have to have these aspects and mandates, and I don't want to say mandates essentially, but these precautions in place. Whether it be wearing a mask in public, hand sanitizer at every station, everywhere you go. Just screen check, or daily checks. I have to do a daily check for COVID every day before I go into work. I said I have to fill out a questionnaire online, and then I also get my temperature taken before I enter the hospital. But I think those are things that we will have to see, going forward. Whether it be not as strict going forward in the future years, I can't really say. Hopefully, I'm a big proponent for the vaccine. I've had the vaccine and the booster in my life, which is, if I get if another booster or vaccine is offered, I'll probably be first in line to do that, just because I know I've witnessed firsthand what COVID can do, from my point of view, as well as what I've learned from our doctors that I've worked with. So I think the key thing for people going forward is just to recognize and understand that COVID's not going away.
So you when you say it's not going away, do you see it just always in existence, or is it going to be like smallpox or the measles or some of those other viruses that have been, I don't want to say cured because there's still a possibility of them being out there, but do you like say 50 years from now, is COVID still going to be
I think
problem?
I think 50 years from now, I think the advances that COVID has done, as we've seen since 2019, I think 50 years from now, I don't know. That's the best way I can put it. I think there's vaccines in place. I think there's boosters in place. I think it's an ever-growing thing. But for the short term, I think right now, COVID vaccines will have to be like flu vaccines, given every year, for a lot of places required. for that's just short term. I think maybe 50, 100 years, we'll see where we're at that point. Could it be like smallpox? Could it be like measles? Could it be like mumps? Things like that. Less relevance. It's a possibility. The medical community is far and away more advanced than I could ever imagine, or I can even wrap my head around. So I think it's a strong possibility that this could be something that we talk about, 50 to 100 years or 100 years from now, as a smallpox, even polio as well, as a possibility. Is just there's a vaccine for it and you have to get it once. But that's all totally up in the air, because we're still dealing with COVID right now, as a rampant variant is going through, South Africa, Africa, and Europe right now. So I think there's the right steps in place. But I think we'll have to deal with it on the short term, more like we do with the flu vaccine and flu epidemic, or I don't want to say epidemic, the flu seasons as we have it.
So the variant you're talking about going through South Africa right now, that's the Omicron. Omicron. Okay, I'm not good with Greek stuff, and yeah. So just in case any future students 50 years or 100 years from now are listening to this, that's the variant that was just newly discovered within the past couple weeks. So you mentioned the advancements of the healthcare community. Are there things you hope healthcare administrators learn or take away from managing these systems during a time of global healthcare crisis?
I think there's a lot we can learn. I think the management information that was put out are just some short term, or just the short things that we can kind of take away from this. You can go into different policies, you can go into different ways you can handle things, but I think the overall management and preparation is the first thing. Like I said, at OU, we were preparing for this in January, before it hit in March. We were, there started to have those meetings where it was like, well, what do we do if this happens? What do we do when it gets here? It went from if to when is the big thing. So understanding that when a pandemic or any type of disease like this, there's a possibility to spread like this, and understanding that that possibility is true, I think is the first thing that a lot of administrators need to come to grips with. Working as an administrator myself, that was something that in the department we oversaw, and we were more than willing to do whatever we needed to do for our health, selfishly, but also the health of our residents and fellows, our students, and then also the faculty as well. And they take the precautions as well. From an information standpoint, I think I think there's over information. Like I said earlier, I was getting my information from 4 sources, trusted sources at that. But I think finding a way to generalize those sources into a better source for people to understand. Whereas there were these different percentages, these different numbers thrown out that a lot of the general population just doesn't understand. I think kind of simplifying that into, this is the percentage that is affected, to what the percentage affected in this area, or something like that. I think there was just too much information that people were looking into, kind of skew numbers in a way that fit what they were looking for. I think looking for a better way to present those in a truthful way is another key that I would take away from that administrators can do. So preparedness for something like this to happen, and then also presenting factual numbers and accurate numbers, but also numbers that people understand, are the biggest things that I would take away from this from an administrative side.
So we're gonna wrap it up with one final question. Now you weren't labeled an essential worker, right?
No, I was not. I was not an essential worker at that point. But our department eventually saw me and my others as essential workers, because we were taking care of healthcare providers.
Okay, so how did you or your colleagues feel about all the public campaigns to label essential workers as heroic?
I jokingly said thank you. I did this, but no. Um, because after they label us as essential, I was like, that's me. But no, I will never take that title. I will never say that, I was a hero. That was nothing. I worked behind the scenes. I worked behind a closed door. I worked at home. I did office work. I oversaw education and, kept hours for our fellows. But no, what our fellows, what our residents did, and even our medical students, what they did and what they risked, because our medical students now, they're practicing doctors from when I first started. They're in their residencies now. So what they saw and they experienced, I mean, that's something that I don't want to say we'll never experience again, but they got to experience a complete nationwide and worldwide shutdown. So labeling those frontline workers, as well as the nursing staffs, the hospitalists, the respiratory therapists, you can go on and on with every little title that goes on into that. Labeling them as heroes, I mean, yeah, you can easily say that they were. They were the ones who were going into work, dealing with COVID patients. I have friends who were in COVID wards, who are, ER nurses when all this was happening. And then obviously, friends, residents, students, and doctors who are on the front line still, as well as the nurses as well. It's something I would want to do, honestly. So labeling as heroes, sure, we can label them as heroes, but they'll say that they were just doing their job. They were, I don't want to say I idolize them, but I admire them for what they've done, the strength they've had, because they've faced unthinkable things, not only from the medical side, the disease point of view, but also in the scrutiny, the long work hours, the stress, all of that goes into it. I think it is admirable what they've done. They've continued to show up to work, and they've helped out a lot. They've done a lot of the things that our doctors essentially needed to do to continue the care of patients. So, and even our doctors as well, continue the care of patients working through the pandemic. But yeah, I admire them, and I have the highest admiration for them, like I said.
All right. Well, Micah Bolin, thank you very much for your time. I just want to remind you that this recording may be used. It will be used for class purpose, but like I said, it will be used for a bigger project on COVID-19 and people's interactions with the virus. And it will be housed at the Oklahoma State University Library as part of a bigger oral history collection. So I just want to say thank you again for your time. And that's the conclusion of our interview. Thank you.
Thank you.